Welcome to this explainer. Today, we're taking on a really crucial mission for our clinical practice. We are shifting our mindset from simple symptom management straight to root cause metabolic interventions. So if you've ever found yourself treating polycystic ovary syndrome by just trying to force a regular cycle, well, you're definitely going to want to pay close attention. Okay, let's just dive right into this.
But before we even look at the data, I want you to commit to an answer and really test your immediate clinical instincts. Just imagine a 26-year-old female patient sitting right there in your clinic. She has PCOS, but she firmly refuses any medications. So what's your absolute best first-line approach to get her health back on track? Just hold that thought.
Here's a quick look at our roadmap. We're going to cover Priya's presentation, check out the PCOS hormonal engine, evaluate our treatment options, break down a 90-day lifestyle protocol, touch on targeted supplementation, and finally wrap it up with high-yield clinical pearls.
Starting off with Section 1, Priya's clinical presentation.
Notice the objective evidence right away on this dashboard. As clinicians, we're always looking for patterns, and Priya's investigations present a really classic narrative. Look at that ultrasound showing polycystic ovarian morphology. You can see 12 or more follicles per ovary there. And right beside it, her testosterone is sitting at an elevated 72 nanograms per deciliter. But honestly, that's just the surface level.
Let's look a little closer. Her fasting insulin is significantly elevated at 18 MIU/L. To put that into perspective, we ideally want to see that number sitting comfortably under 10. This right here, this is the smoking gun of underlying insulin resistance. Furthermore, her LH to FSH ratio is wildly inverted at 3.2 to 1. In a normal physiological state, we expect that ratio to be under 2. So this inversion is a classic sign we look for in these presentations. It tells us there's a major disruption happening in the brain-ovary communication axis. And that brings us to a real-world dilemma that you are going to face countless times in practice. Priya sits across from you and says, "Doctor, I don't want medicines. Can lifestyle alone fix my PCOS?" This leaves you to decide between option A, an immediate OCP to regularize her cycles, option B, a dedicated 3-month lifestyle intervention, or option C, going straight to metformin for the insulin resistance. Drop your answer in your mind right now.
Let's move to Section 2, the PCOS hormonal engine.
The fundamental concept to grasp here is that PCOS isn't just some isolated gynecological issue. It operates as a vicious endocrine cycle fundamentally rooted in hyperinsulinemia. It's really a systemic metabolic state that just loops in on itself. Let's actually trace exactly how this engine runs. Follow the pathophysiology with me here. It starts right at the top, with insulin resistance. This hyperinsulinemia directly stimulates the ovaries and disrupts pituitary function, which causes that LH surge we saw in Priya's labs. Now, this LH surge, combined with high insulin, forces the ovaries to ramp up androgen production. The excess testosterone then halts follicular development, leading to anovulation and cyst formation. And the kicker? This whole process drives further weight gain, which continuously feeds right back into worsening the initial insulin resistance. The cycle just repeats and gets stronger, unless we forcibly break it.
Next up, Section 3, evaluating treatment options.
Now, as doctors, we so often jump straight to option A, oral contraceptive pills, right? Because they regularize cycles fast and they clear up acne. But OCPs are really just a physiological band-aid. Most importantly, they do absolutely nothing to treat the root cause of underlying insulin resistance. The literal second the patient stops the pill, the symptoms just roar right back. Even worse, we miss the critical window for a long-term metabolic fix, and some formulations can actually exacerbate weight gain. Let's look at option B and see how this builds a much stronger clinical foundation. In stark contrast to a band-aid, a targeted lifestyle intervention acts as a true metabolic cure. Just look at where the lightning bolts are striking in this diagram. A low GI diet and exercise directly shatter the insulin resistance block. As insulin drops, the LH surge calms down. Concurrently, even a 5% reduction in weight massively decreases adipose androgen production and aromatase activity, which naturally restores ovulation. So the crucial point we're comparing here is pretty profound. We're weighing the temporary symptom control of an OCP, which is a totally superficial fix, against the physiological root cause metabolic intervention of dedicated lifestyle changes. For a patient like Priya, the choice becomes very, very clear clinically.
Moving on to Section 4, the 90-day lifestyle protocol.
The triad of this 90-day protocol is non-negotiable.
First, low GI nutrition featuring high fiber, complex carbs to systematically blunt those insulin spikes. Second, targeted exercise. That's 150 minutes of moderate aerobic work a week, plus resistance training twice a week to literally force the muscles to become more insulin sensitive. Third, and this is so often ignored, sleep and stress management. Getting 7 to 8 hours of quality sleep is biologically necessary to regulate cortisol, which otherwise just drives up those androgens.
To make this actionable, you really have to use culturally relevant dietary advice. For example, use an India-specific guide like this one. Don't just tell them to eat complex carbs. Advise patients to eat local staples like ragi, jawar, and moong dal. Tell them to strictly avoid refined maida, sugary chai, and late-night eating habits. When you give them a visual plate like this, half greens and micronutrients, a quarter protein, a quarter complex carbs, adherence absolutely skyrocket.
Let's look at Section 5, Targeted Supplementation.
We can perfectly map specific evidence-based supplements directly to their clinical mechanisms. This isn't guesswork, guys, it's targeted medicine. For instance, prescribing inositol, specifically the Mayo and D-Chiro blend, directly improves ovarian insulin signaling. If your patient is complaining heavily of hirsutism and acne, adding zinc offers excellent targeted control. And NAC provides phenomenal antioxidant support for egg quality, which is super important, especially in anovulatory patients.
Finally, Section 6, High-Yield Clinical Pearls.
Pay really close attention to this classic NEET PG stem. We've got a 26-year-old obese female with oligomenorrhea, hirsutism, bilateral PCO on ultrasound, and an LH to FSH ratio of 3:1. When they ask for the most appropriate first-line management, it proves that lifestyle modification and weight reduction is the undisputed correct answer. It beats out OCPs, it beats out clomiphene citrate, and it certainly beats laparoscopic drilling.
And to even get to that diagnosis in the first place, you absolutely must memorize the Rotterdam criteria. It's a triad: oligo or anovulation, clinical or biochemical hyperandrogenism, and polycystic ovarian morphology on USG. Remember the golden rule here. You only need 2 out of these 3 presentations to confirm a PCOS diagnosis. A patient actually doesn't need cysts on her ovaries to have PCOS if she hits the other 2 criteria.
Finally, make sure to keep these 2 crucial pharmacological pearls in your back pocket. First, if you do need to induce ovulation, letrozole is now the preferred drug of choice over clomiphene because it carries a much lower multifetal risk. Second, metformin is strictly an adjunct for insulin resistance. It is never a primary fix, and it is certainly not for lean PCOS without insulin resistance.
Let's conclude this explainer by turning the lens back on our own practice. We've seen the data, we understand the vicious hormonal cycle, and we know that a 90-day protocol actually targets the root cause. So I want you to ask yourself honestly, how will this pathophysiological understanding directly alter the very next PCOS prescription you write tomorrow? Are you going to reach for the Band-Aid, or will you fix the engine? Think about it. Thanks for joining me on this deep dive.